So we'll go ahead and get started, and you probably heard that voice right there. Just for your information, this presentation will be recorded. So welcome everyone to Therapy Ed's online office hours, where this month I'm your host, Dr. Michael Crowell, and we'll discuss the clinical practice guidelines for lateral ankle ligament sprains. That's the 2021 revision. Before we get started, just a little bit of housekeeping. Please make sure that your microphones are on mute. And as I said, the session will be recorded. We'll do a question and answer following the session. So if you have questions, please just write them down on a sheet of paper and we'll get to them afterwards at the end of the presentation. So first, if you would in the chat, everybody that's here tonight, would you just type into the chat when you plan on taking the board exam? Okay, so some July, but a lot of people, good luck, are taking them next week. Great. Good. So some July, some next week. Excellent. Well, everybody that's taking it in April, good luck. I know you'll probably do great, but hopefully this information that you'll get here tonight will help you with preparation for that exam. So first, I'd like to introduce myself. I'm, like I said, Dr. Mike Crowell. I'm currently an associate professor in the Doctor of Physical Therapy program at the University of Scranton in Pennsylvania. I was recently retired. I was an active duty Army Lieutenant Colonel. I have 18 years of experience in orthopedics and sports physical therapy, and I just left West Point as the fellowship director there for the West Point Division I Sports Physical Therapy Fellowship. Throughout my time in the Army, I've had a variety of clinical and leadership roles. I've been a clinic chief for a number of smaller clinics. I've worked in the Surgeon General's office on a health and wellness project called the Performance Triad. And I was at the West Point Fellowship actually for 8 of the past 10 years. Prior to becoming the program director, I was on faculty there as well. I also deployed to Iraq as a brigade physical therapist with the 101st Airborne Division. And I've got a little bit of a unique career, but I was in the Army before I was a physical therapist. I was a field artillery officer stationed in Germany. So you can see some of the pictures on the right there from my time in the Army. The top middle one there is my time as a field artillery officer doing some work in a fire direction center. That right picture there is what clinic, an austere clinic in Iraq would look like. And down at the bottom there are some of my teaching roles at West Point, teaching some manual therapy to our fellows and some other places. All right, so let's talk about what we're going to talk about tonight, which is the objectives for tonight. We're going to talk about, apologize for the slide. It's going to be the ankle clinical practice guidelines. I just want to draw your attention to the bonus content on the bottom there. That's going to be information that's above and beyond the clinical practice guidelines. And although it's unlikely to be directly tested on the board exam, it does provide additional depth and context, which is going to definitely help you answer questions, and they'll be useful definitely in your clinical practice. So we like to say that these clinical practice guidelines, they're kind of like a one-stop shop. You get a lot of background information, and then some information on both the diagnosis, examination, and then the evaluation and intervention section. So you get kind of everything all at once. Now, when you look at the content of the exam, this is what it is right here. And so you can see that the musculoskeletal system is a very large portion of that content, 27%, with some of the other systems you can see there. And when you break it down a little bit farther, you can see in blue is examination, orange is the evaluation, differential diagnosis, and prognosis, and the silver is intervention. Again, that's a vast majority of the exam that you're going to see. Please put your microphone on mute if you haven't already done so, please. Thank you. So then when you break it down a little bit farther, let's look specifically at the musculoskeletal content and how many questions do you think you might see on each of these? So for exam, if the musculoskeletal portion is 27% of the exam, within that, 24% of that is going to be on examination. So you could see somewhere from 14 to 18 questions. The next one, evaluation, differential diagnosis, and prognosis, you could see anywhere from 15 to 18 questions, or 32%. And then lastly, intervention is 29%, and you could see anywhere from 15 to 18 questions. So overall, if you added all those up, somewhere from in the range of 44 to 54 questions on your board exam are going to be related to musculoskeletal content. So here's the correct slide. Here is our lateral ankle ligament sprains objectives. We're going to go over these in pretty good detail, and then we're going to have about 5 simulated national licensure exam questions that we'll go over. And so hopefully get you guys prepped for getting ready for that exam. And again, bonus content there is not likely to be directly tested, but it's going to give you a little bit more depth, maybe help you understand the information a little bit better. These are the references that this information is taken from. The primary one is the Therapy Ed National Physical Therapy Exam Review and Study Guide, but then also taken some information from Bruckner and Collins Clinical Sports Medicine, your biomechanics book, Joint Structure and Function, and then McGee's Orthopedic Physical Assessment. All right, before we review the clinical practice guidelines, let's take a step back and review the relevant anatomy and biomechanics of the ankle joint complex, or the hindfoot. So the ankle joint complex consists of 3 joints: the talocrural, the subtalar, and the tibiofibular joints. And the talocrural joint's a mortise hinge joint formed by the articulation of the trochlear surface of the talus with the medial and lateral malleoli. And the trochlear surface is gently concave and it's wedge-shaped, slightly larger anteriorly than posteriorly, and that plays a role in joint motion. Major ligaments of the talocrural joint are laterally the anterior talofibular ligament, or the ATFL. So we see that here. The calcaneofibular ligament, or the CFL, shown here, and the posterior talofibular ligament, or the PTFL, here. Then medially, we have the deep fibers are the anterior and posterior talotibial ligaments, and superficially is the deltoid ligament. And we see those here. The ATFL, with its mostly horizontal oriented fibers, restricts anterior translation and some internal rotation. The CFL, with its mostly vertical oriented fibers, restricts straight inversion. And then the deltoid ligament primarily restricts eversion and external rotation. The subtalar joint consists of 2 separate articulations of the talus and the calcaneus, posterior and anterior. The posterior articulation is also known as the subtalar joint proper. And the major ligaments of the subtalar joint are the interosseous talocalcaneal ligament and the lateral, posterior, and medial talocalcaneal ligaments. The distal tibiofibular ligament is a plain joint formed by the articulation of the distal tibia and fibula. This joint allows widening and narrowing of the mortise that accommodates the wedge shape of the trochlea. And the ligaments of the distal tibiofibular joint are the anterior, the posterior, and the interosseous tibiofibular ligaments. The motions available at the ankle and foot are dorsiflexion and plantar flexion in the sagittal plane, inversion and eversion in the frontal plane, and abduction and adduction in the transverse plane. Pronation and supination are a combination of each of these motions. In non-weight bearing, pronation is a combination of dorsiflexion, eversion, and abduction, while in supination, it's a combination of plantar flexion, inversion, and adduction. And shown on this slide are the resting, closed-packed, and open-packed positions of the tibiofibular, talocrural, and subtalar joints. The closed-packed position for both the tibiofibular and the talocrural joints is maximum dorsiflexion, and the closed-packed position for the subtalar joint is in supination. The talocrural joint is primarily responsible for dorsiflexion and plantar flexion, with a normal range of motion of 20 degrees and 50 degrees respectively. And as I noted in the last slide, the trochlea is wider anteriorly than posteriorly. And so as the ankle moves into dorsiflexion, the mortise is widened and stability is enhanced. In the open chain during plantar flexion, the talus anteriorly glides in the mortise, and dorsiflexion is the opposite motion. In the closed chain, during plantar flexion, the tibia glides posteriorly on the talus, and the axis of the talocrural joint is slightly rotated laterally, approximately 23 degrees, and inferiorly, approximately 14 degrees. Subtalar joint motion is triplanar, and it occurs in the same direction when mobilizing the calcaneus on a fixed talus. And in the open chain during inversion, the calcaneus moves into adduction, supination, and plantar flexion on a fixed talus, and eversion is the opposite combination of movement. And then in the closed chain during inversion, there's supination of the calcaneus, where the talus glides laterally, with abduction and dorsiflexion of the talus, ultimately producing external rotation of the tibia. An eversion occurs as a reciprocally opposite motion, ultimately producing internal rotation of the tibia. And normal range of motion of supination is 40 to 60 degrees, and pronation is 15 to 30 degrees. And the muscles that contribute to anterior stability are the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus muscles. The tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus muscles stabilize the medial ankle. And then the peroneus longus and peroneus brevis muscles stabilize the lateral ankle. There are also retinacula that constrain the tendons. Particularly important is the superior peroneal retinaculum that prevents peroneal tendons from subluxing out of their groove posterior to the lateral malleolus. So now that we've refreshed ourselves on some of the anatomy and biomechanics, let's get into the clinical practice guidelines for lateral ankle ligament sprains. All right, lateral ankle ligament sprains are extremely common. Exactly how common is unknown. Approximately 50% of individuals who sprain their ankle don't even seek medical attention. But regardless, ankle sprains are the most common foot and ankle and sports-related injury that individuals seek medical care for. Full prevalence from systematic reviews is 12% in the general population. The greatest prevalence is in children 12 and younger at 13%, and then the prevalence in adolescents, 11.4%, is slightly greater than adults at 10.5%. Depressingly, for the field of physical therapy, only 7 to 11% of those who seek care are referred to a rehabilitation specialist within 30 days of their injury. And the risk is different based on gender, with females having twice the injury rate as males. 40% of all ankle sprains occur in sports, and then collegiate athletes are at a greater risk than high school athletes. Now, chronic ankle instability has been defined as repetitive bouts of lateral ankle instability, resulting in numerous ankle sprains. The prevalence varies depending on ages, with approximately 1% of young adults, 20% of adolescent athletes, and 23% of high school and collegiate athletes having this condition. Chronic ankle instability may develop in 40% of individuals who've sought care for a first-time lateral ankle sprain. Risk factors for lateral ankle sprains include female sex, hip weakness, poor balance, and exposure to athletic activities that may injure the ankle. Risk factors for chronic ankle instability are no prophylactic bracing, poor rehabilitation after an initial acute lateral ankle sprain, higher BMI, and then sports exposure. Patients with lateral ankle sprains demonstrate altered movement patterns throughout the kinetic chain and even on the uninvolved extremity. Those changes may be protective to prevent re-injury and typically rely on increased activity at the hip and knee to reduce the forces at the ankle. Now, specific sensorimotor and range of motion impairments in lateral ankle sprains are decreased ankle strength, perineal muscle reaction time, and ankle dorsiflexion of plantar flexor and range of motion, with increased frontal plane range of motion and midfoot and forefoot mobility. So they compensate with the forefoot and midfoot for their lack of ankle range. Those with persistent pain after ankle sprain may have an additional injury that accounts for their symptoms. Some common additional injuries are occult fractures, osteochondral injuries, ankle impingement, perineal tendon injuries, and peripheral nerve injuries, some of which I'll discuss in more detail later. Copers, they're defined as those who achieve at least a moderate level of activity and have near normal self-reported function within 12 months. Those who have continued complaints of instability are considered to have chronic ankle instability. And patients with chronic ankle instability have similar impairments to lateral ankle sprains, but may also have impaired centrally mediated processes in both the injured and uninjured lower extremities. And the clinical course following ankle sprains is usually a rapid recovery within 2 weeks, with return to sports within 1 to 3 weeks. While individuals may return to activity relatively quickly, full recovery of physical performance might take months or even years. The role of injury severity on prognosis is not fully established at this time, and patients may complain of persistent ankle pain and instability, with 5 to 33% reporting persistent symptoms at 1 year and 15 to 50% at 3 years. Supervised impairment-based rehabilitation allows for faster recovery, and it also may reduce the risk for re-injury. The clinical course for chronic ankle instability is not as well established. Patients with chronic ankle instability demonstrate reduced physical activity, participation, and overall health-related quality of life. A functional treatment program that targets jumping and landing biomechanics improves self-reported functional status with a large effect size using the patient self-reported foot and ankle ability measure. And a systematic review-based consensus statement recommended non-surgical treatment for at least 3 to 6 months before considering surgical intervention in patients with chronic ankle instability. A high-quality exam of the ankle is going to combine key information, both the patient history and then the physical examination. Patients with acute lateral ankle sprains typically report traumatic inversion-related injury. They often report hearing or feeling a pop at the time of the injury. Screening with the auto ankle rules, as we'll discuss in some later slides, is mostly negative. And the patient will be able to bear weight, although with some amount of pain. One of the main findings on the clinical exam is a painful loss of ankle dorsiflexion range of motion. And this can be assessed in either weight-bearing or non-weight-bearing. Patients will frequently have tenderness in the anterolateral ankle region over the ATFL and CFL, and then they're going to perform poorly on tests of balance and jumping. And two special tests of value are the anterior drawer test and the reverse anterolateral drawer test, both of which primarily assess the integrity of the ATFL. Patients with chronic ankle instability report a history of at least one sprain, intermittent giving way or instability, and possibly a prior history of treatment for a lateral ankle sprain. Two self-report tools, the Cumberland Ankle Instability Tool and the Identification of Functional Ankle Instability, they can both help classify chronic ankle instability. Scores of 25 or less on the Cumberland Ankle Instability Tool and 12 or greater on the Identification of Functional Ankle Instability are indicative of chronic ankle instability. On physical exam, patients with chronic ankle instability present with sensor and motor deficits, and they usually perform poorly on a battery of physical performance tests. Now, the ankle is the most frequently misdiagnosed region for patients reporting to the emergency department. Not all injuries are as obvious as the one that you see pictured here, where this soldier presented to our troop medical clinic in Iraq on the second day after we arrived in 2008 with an injury sustained while he was playing basketball during off-duty time. And now the most common reasons for misdiagnosis are poor history taking and physical exam and failure to appropriately order and or interpret radiographs. And the auto ankle rules are a key part of this process, used to assist in ruling out fracture. Listed on this slide are some of the differential diagnoses which should be considered in a patient with suspected lateral ankle sprain. The degree of concern for these diagnoses should increase if a patient's not making progress consistent with the prognosis that we discussed in earlier slides. For example, the diagnosis of occult fracture and osteochondral lesions should be considered if the patient reports continued pain and inability to resume their normal physical activities 8 weeks after an acute ankle sprain. And shown here are the auto ankle and foot rules. Physical therapists are now practicing in both emergency departments and other direct access settings. And when they're used in the emergency department, utilization of the auto ankle rules decreases costs, reduces patient wait times, reduces length of stay, and reduces the ordering of unnecessary radiographic imaging. And there's also evidence that the auto ankle rules can be used during athletic events. So to apply the auto ankle rules, a clinician should look for 3 key elements. In the ankle, the key elements are bony tenderness at the posterior edge or tip of the posterior medial malleolus, bony tenderness or posterior edge of the posterior edge or tip of the posterior lateral malleolus, and then inability to take 4 complete steps immediately and in the emergency department. In the foot, the key elements are bony tenderness at the base of the 5th metatarsal, bony tenderness of the navicular, and inability to take 4 complete steps immediately and in the emergency department. And so some key points to remember: palpate the entire distal 6 centimeters of the fibula and the tibia, and these rules don't apply to patients under 18 years old. The sensitivity of the auto ankle rules has been reported as 92 to 100%, and the specificity is lower at 8 to 68%. Screening tests, such as the auto ankle rules, need to minimize false negative results, which occur with tests having high sensitivity. So using the mnemonic SNOUT, a highly sensitive test with a negative result helps us rule out a condition. In this case, we're ruling out a fracture with the auto ankle rules. Likelihood ratios, they combine sensitivity and specificity and are independent of disease prevalence. In plain language, likelihood ratios tell us how much more likely it is that a person has the diagnosis after the test is done. And if we have a positive test, we're more concerned with the positive likelihood ratio. And if we have a negative test, then we're more concerned with the negative likelihood ratio. So as an example, let's consider a direct access patient with an acute ankle inversion injury and a negative screen with the Ottawa ankle rules. Let's assume worst case that there's a 15% prevalence of fractures when someone's seen in the emergency department with an ankle injury, which is based on previous literature. And after a negative result on the Ottawa ankle rules, the probability of an ankle fracture would decrease to only about 1.4%. And that probability would decrease even further if we assume a lesser pretest probability of the fracture. These clinical practice guidelines also made some specific recommendations regarding patient-reported outcome measures and physical impairment measures. So there's strong evidence to support the use of patient-reported outcomes to assess changes in function for both acute lateral ankle sprains and chronic ankle instability. The Patient-Reported Outcome Measure Information System, or PROMIS, that's a computer adaptive test, and the PROMIS Physical Function Subscale, and the PROMIS Pain Interference Subscale, the Foot and Ankle Ability Measure Sport Subscale, are all sensitive and responsive to changes in patient-reported health. And additionally, the Tampa Scale of Kinesiophobia and the Fear Avoidance Belief Questionnaire can assess fear of movement and re-injury along with fear avoidance beliefs in patients with chronic ankle instability. There's also strong evidence to support assessment of key impairments at baseline and at least 2 additional time points to gauge the patient's progress and predict treatment success. Physical therapists should specifically measure ankle dorsiflexion with the weight-bearing lunge test, static single leg balance with eyes closed on a firm surface, and dynamic balance with a modified star excursion balance test, also known as a Y balance test. The physical examination should also assess ankle swelling, range of motion, talar translation, talar inversion, and static single leg balance. So shown here is the lower extremity functional scale. It's a valid and reliable measure of general lower extremity function and asks the patient to rate various activities such as squatting, running, and hopping on a scale from extreme difficulty to no difficulty. Each individual activity is scored from 0 to 4, with a total scale score ranging from 0 to 80, and greater scores or bigger numbers equal better function. The minimal clinically important difference, or the MCID, which is the difference where the patient will notice a meaningful change on this scale, is 9 points. This is the foot and ankle ability measure, or the FAME, and it's also a valid and reliable measure, but this one is just of ankle function. On this scale, also asks the patient to rate various activities specific to ankle function this time, though, such as running, jumping, and landing on a scale from extreme difficulty to no difficulty. There's 2 subscales, an ADL subscale and a sports subscale. Each individual activity is scored from 0 to 4. The ADL scale ranges from 0 to 84, and the sports subscale ranges from 0 to 32. And on both subscales, a greater score is equaling better function. And so the MCID for this ADL subscale is 8 points, and the sports subscale is 9 points. There's many ways to assess weight-bearing ankle dorsiflexion. I'll review some of these on the next 2 slides. However, listed here are a few of the key points for discussion. All patients should be able to achieve a minimum amount of gross range of motion to reduce risk for injury and to clear the patient for return to sports. Patients should be able to achieve at least 9 to 10 centimeters in the knee to wall method, or 35 to 38 degrees when assessed with an inclinometer. You'll see that in the next slide. Weight-bearing measures may be more likely to detect a treatment effect. And then side-to-side comparison is not really the best way to gauge progress here, as there's normally a side-to-side asymmetry in even normal individuals. So here's the 3 common measures of weight-bearing ankle dorsiflexion: the tape measure on the floor, a digital inclinometer, and a traditional goniometer. And as shown in the table here, all the 3 measures are reliable. There's also a quick screening method that you can use to observe the movement of the tibial tuberosity when lunging in a tandem stance position. And the tested extremity in these cases is to the rear. The patient lunges forward while the physical therapist observes from the side. If the tibial tuberosity stops behind the medial malleolus, then they're considered behind. So that's annotated. The medial malleolus is the yellow band here on the slide. If the tibial tuberosity falls within the yellow band, which is defined as the width of the medial malleolus, they're considered within. And then finally, if the tibial tuberosity stops in front of the medial malleolus, they're considered beyond. And this method is also reliable. So in this study sample, patients measuring behind averaged 41 degrees of motion, while those measuring beyond measured 52 degrees of motion. The star excursion balance test measures dynamic balance. This test was initially developed to test 8 different directions. Think of the 8 potential directions of a compass, like north, south, east, west, and northwest, southwest, and so on. But then it was modified to include only the most meaningful information in the anterior, posterior lateral, and posterior medial directions. This test can screen for postural control deficits, can predict lower extremity injury, and can assess changes in dynamic postural control that are the result of an intervention. Basketball players with an anterior right to left reach difference of more than 4 centimeters were 2.5 times more likely to sustain a lower extremity injury. And additionally, female athletes with a composite reach score of less than 94% of their limb length are 6.5 times more likely to sustain a lower extremity injury. So, i.e., patients with better balance are less likely to get injured, and patients with worse dynamic balance are more likely to get injured. To perform this test effectively, there's some key considerations listed on the slide. So shoes should always be off. There's a learning effect with the test. That means the patient gets better after they do each repetition. So you wouldn't want to confuse that with improvement in function. So for research purposes, we use 6 practice trials and average 3 graded trials. Given that time commitment, that might not be feasible in a clinic, but you should at least try to stay consistent. And this article here recommends at least 4 practice trials. Testing order should also be consistent. So according to the authors of this study, all trials in the anterior direction should be done first, then all trials posterior medial, and finally all trials posterior lateral. The stance foot should move minimally, i.e. no heel lifting, and then the trunk should remain under control. And then lastly, the hand should remain on the hips to standardize movements outside of the trunk and the lower extremity. So now, before we get into our special tests for the ankle, let's go back one more time to sensitivity and specificity and likelihood ratios. It's definitely an important concept to understand when you're trying to understand the value of special tests. So a sensitivity is a test's ability to obtain a positive test when the target condition is really present or a true positive. And the formula for sensitivity is true positives divided by the true positives plus the false negatives, or A over A plus C. Specificity is a test's ability to obtain a negative result when the condition is really absent or a true negative. And this one we use the mnemonic SPIN. So the formula for specificity is true negatives divided by false positives plus true negatives, or D over B plus D. But the weakness of sensitivity and specificity is they're influenced by the prevalence of the condition, which means when the studies examine how good these perform in clinical practice, when the studies are done, how many people that actually had the condition in that study influences how good these tests are. So likelihood ratios tell us the probability a patient has the condition after the test is done, and these are independent of disease prevalence because they combine all of this information. Tests with small negative likelihood ratios should be utilized early in the exam to help rule out alternative diagnoses, and tests with large positive likelihood ratios should be used late in the exam to rule in the primary diagnosis. So the formula for a positive likelihood ratio is sensitivity divided by 1 minus the specificity. And the formula for a negative likelihood ratio is 1 minus the sensitivity divided by the specificity. So one more time, let's use the example nomogram on the right. And this time we're just going to consider a general condition with a pretest probability of 30% and a negative likelihood ratio of 0.2 with a negative test result yields a post-test probability of 5 to 6%. However, alternatively, a positive test result and a test with a positive likelihood ratio of approximately 3 is going to yield a post-test probability of almost 60%. So you can see how the probability changes based on the magnitude of that likelihood ratio, but also the pre-test probability that you assign. So in this table from the review and study guide, shown in the red boxes are the best tests for lateral ankle ligament injuries. The anterior drawer test and the Taylor tilt test are 2 of the better tests for lateral ligaments. Both tests appear to be more specific than sensitive, with a better positive likelihood ratio than negative likelihood ratio. This means that while a positive test increases the probability of a lateral ankle ligament injury, a negative test is not as meaningful. The reverse anterior lateral drawer test mentioned previously, that's biomechanically very similar to the anterior drawer test. And so in the absence of diagnostic test studies, a physical therapist might consider their diagnostic ability to be about the same. And we'll discuss these two tests right in the next slide. The anterior drawer test designed to primarily test for injuries to the anterior talofibular ligament, the most frequently injured ligament in the ankle. The PT stabilizes the tibia and the fibula, holds the patient foot in 20 degrees of plantar flexion, and translates the talus forward. And a dimple may appear over the area of the anterior talofibular ligament, or the ATFL, if pain and muscle spasm are minimal, called a dimple or a suction sign. Thinking back to our anatomy, in the plantar flex position, the ATFL is perpendicular to the long axis of the tibia. By adding inversion, which gives us an anterior lateral stress, the examiner can increase the stress on the anterior talofibular ligament and the calcaneofibular ligament. A positive anterior drawer test may be obtained with a tear of only the ATFL, but anterior translation is greater if both ligaments are torn, particularly if the foot is tested in dorsiflexion. However, if straight plane anterior translation is increased, the test indicates both medial and lateral ligament insufficiencies. That means that both the superficial and the deep deltoid ligaments, as well as the ATFL and the anterior lateral capsule, have been torn. If the tear is on only one side, as you're seeing here in this figure, only that side is going to translate forward. The knee should be in 90 degrees of flexion to alleviate tension on the Achilles tendon. And then the test should be performed in plantar flexion and in dorsiflexion to test for straight and rotational instabilities. The reverse anterolateral drawer test is performed by stabilizing the foot and the talus, and then translating the tibia and fibula posteriorly on the talus. In this case, excessive posterior translation of the tibia and fibula on the talus indicates a positive test. Although not included with the clinical practice guidelines, PTs should also be aware of the potential for syndesmosis injuries to occur either in isolation or in conjunction with lateral ankle ligament sprains. And shown here are the best tests for the syndesmosis. This happens frequently with orthopedic special tests. They're more specific than sensitive, and they have better positive than negative likelihood ratios. The mechanism of injury in syndesmosis injuries is shown in the two pictures on the top of the slide. It's an injury that frequently occurs during football, rugby, and other collision sports. And in this injury, the foot's forced into external rotation. So the external rotation stress test, in this test, the patient is seated with the leg hanging over the table with the knee at 90 degrees of flexion. The PT stabilizes the leg with one hand, and then with the other hand, they hold the foot in neutral and apply a passive external rotation stress force. And this test is positive for a syndesmosis or a high ankle sprain if the pain is produced over the anterior or posterior tib-fib ligaments and the interosseous membrane. Pain medially and excessive movement of the talus may indicate a tear of the deltoid ligament as well. For the squeeze test, the PT grasps the lower leg at the mid-calf and compresses the tibia and fibula together. And pain in the lower leg may indicate a syndesmosis injury, provided that fracture, contusion, and compartment syndromes have been ruled out. And the length of tenderness above the lateral malleolus helps going to determine the injury severity and then also their prognosis. The West Point ankle sprain grading system. That is one system that can be used to evaluate the severity of ankle injuries, including lateral, medial, and syndesmosis sprains. Now, grade 1 injuries, they result in no instability. There's only mild to moderate discomfort with stability testing. In lateral ankle sprains, the ATFL is tender, there's localized swelling, minimal ecchymosis, and the patient remains very functional. In grade 2 injuries, there's now some degree of instability, and there's moderate to intense discomfort with stress testing. The ATFL and CFL are likely tender, there's significant ecchymosis, and the patient's function is impaired. And grade 3 injuries are the most severe. They result in definite instability of the ankle joint. There's diffuse and severe swelling and ecchymosis and tenderness to all the major lateral ankle ligaments. Patients with grade 3 ankle sprains are unable to bear weight. Now, as shown, syndesmosis sprains can also be graded on the scale. Moderate to severe lateral ankle sprains may also be a combination of lateral, medial, and syndesmosis sprains. so it can be more than just one. This is another classification system that's specific to acute lateral ankle sprains and describes the range of severity that's present in these injuries. Again, grade 1 injuries are mild and stable, with the anterior drawer and talar tilt tests likely negative. Grade 2 injuries are moderate and stable, often with demonstrating positive anterior drawer test with a negative talar tilt test. And then grade 3 injuries are the most severe and unstable. They'll likely present with a positive anterior drawer and a talar tilt test. Recovery time for grade 1 injuries averages about 8 days. For grade 2 injuries, averages 20 days, and grade 3 injuries averages about 40 days. When patients do not recover within the time frames expected, additional diagnoses within the differential diagnosis should be considered. This is a table from the Bruckner and Kahn Clinical Sports Medicine textbook and shows potential differential diagnoses associated with persistent pain after a lateral ankle sprain. As you can see, the source of persistent pain may be fracture, bony impingement, an atypical sprain, tendon injury, or other soft tissue or neurologic pathology. And shown in red are fractures and bone pathology that can be easily missed in the setting of an ankle sprain. So in the next few slides, I'll discuss these in more detail using cases that we've seen at West Point. So this was a 20-year-old military cadet presented to a direct access clinic with left lateral ankle pain. He was injured 10 days earlier when he was running downstairs. He missed a step and suffered an inversion ankle injury. He was able to bear weight immediately with tolerable pain, which he self-managed with ice. And he continued to train for an upcoming intensive dive course that included weight training, running, swimming, despite his persistent symptoms. On exam, there was no swelling or ecchymosis and gait was normal. The anterior drawer test and the talar tilt test were negative, but pain was elicited with a heel tap and with palpation of the anterior process of the lateral calcaneus. And then radiographs were ordered to rule out a fracture due to the presence of persistent symptoms and bony tenderness. And these are the oblique and lateral radiographs of the left foot and ankle showing a non-displaced fracture of the anterior process of the left calcaneus, and that's highlighted by the orange circle. The patient was immobilized with a walking boot with weight bearing as tolerated, then referred to an orthopedic surgeon who recommended maintaining the weight bearing as tolerated in the cam boot for 6 weeks. He began weight bearing exercises at 6 weeks, and at 10 weeks, he returned to jogging without increased pain. So one of the learning points in this case is with tenderness of the anterior lateral calcaneus, ankle radiographs are usually appropriate according to the American College of Radiology appropriateness criteria. While the current Ottawa ankle rules do not include tenderness of the calcaneus, the original Ottawa ankle rules included this area, and validation refinement studies reported very few fractures of this anterior process of the calcaneus. Up to 5% of lateral ankle sprains are associated with an anterior process of calcaneus fracture, but they're often misdiagnosed. This patient was a 20-year-old male cadet who had a left medial and lateral ankle pain after rolling his ankle playing soccer. Now he planted his left foot. He tried to run to the left and rolled his ankle, and he thought the mechanism was inversion. He was able to put minimal weight through the ankle and limp off the field, but he required assistance to walk back to his room after that, and then noticed increased swelling and bruising later in the day on both the medial and lateral ankle. On exam, his gait was antalgic, but he was able to bear weight. There was generalized swelling and lateral foot ecchymosis. The lateral and medial malleoli, the ATFL, CFL, and deltoid ligament, they were all tender to palpation. Range of motion was limited and painful in all the planes, and the anterior drawer test showed mild laxity, but the talar tilt test was negative. So in this case, radiographs were ordered because of tenderness at the lateral malleolus. In figure 1, a right mortise view radiograph of the ankle, you see the lateral process of the talus fracture in the red circle. The radiologist recommended an ankle CT, which is shown in figure 2, and shows the fracture more clearly. After 8 weeks, he was progressing well and was ready to start a run progression, and he progressed back into running without limitations over a summer, but we weren't able to follow him because of the academic year summer break. Fractures of the posterior process often occur with forced plantar flexion of the ankle, shown here in the red circle. They can also be caused by a combination of dorsiflexion and pronation, which happens in snowboarding a lot. And this injury does occur rather frequently at West Point. Initial radiographs can be negative, and a CT would be ordered to definitively rule out this fracture. While osteochondral lesions are not fractures, they are a bone lesion. and they're characterized by the presence of a chronic deep ache in the ankle. The superior medial talus is the most common region of the talar dome affected, as shown in the top right by the black arrow. On T2 weighted MRI of the ankle on the bottom right, the yellow arrows highlight the high signal intensity that indicates the presence of an osteochondral lesion and the associated subchondral bone edema. So seeing that right there. As we get into interventions, there are many interventions available to PTs for the rehabilitation of patients with acute lateral ankle sprains. So for this presentation, we're going to focus on those interventions that were rated as having A-level evidence with strong recommendations in the clinical practice guidelines. On this slide, we'll focus on prevention. To review, primary prevention refers to preventing the first occurrence of an injury, and secondary prevention refers to prevention of injury recurrence once that injury has already happened initially. There's strong evidence to support prophylactic bracing and taping for the prevention of first-time ankle sprains, particularly if the risk factors are present. And surprisingly, bracing is more cost-effective than taping. Experience with taping and patient or athlete preference should be considered when deciding between taping and or bracing. There's also strong evidence to support prophylactic bracing for the prevention of ankle sprain recurrence. Balance focus therapeutic exercise should also be utilized to address sensory-motor impairments identified during your physical examination. There's strong evidence to support optimized loading, beginning in the acute phase of the injury and continuing into the post-acute phase. Immobilization should be considered for more severe injuries for a period of no more than 10 days, and otherwise patients should be encouraged to progressively bear weight and utilize appropriate external support. Therapeutic exercise continues to be the mainstay of ankle sprain rehab. There's strong evidence to support a rehabilitation program consisting of neuromuscular training, postural re-education, and balance training, although the composition of the rehabilitation programs and research is really variable. Physical therapists should tailor their therapeutic exercises to specific impairments and functional limitations identified during the exam. And in patients with more severe injuries, supervised rehab appears to be better than a standalone home exercise program. Since the publication of the 2013 ankle sprain clinical practice guidelines, additional published research has emerged in favor of including manual therapy as part of the overall rehab program. There's strong evidence to support including manual therapy to reduce pain and improve short-term ankle dorsiflexion range of motion. And combining manual therapy with therapeutic exercise appears to produce the optimal effects. And there's no research to support specific techniques, so selection should be based on individual patient impairments and your kind of skill as a therapist. Techniques to consider may be lymphatic drainage, joint mobilization techniques, soft tissue mobilization techniques, and mobilizations with movement. These clinical practice guidelines are unique in that they recommend not to perform a specific treatment modality. So there's strong evidence from systematic reviews that ultrasound is not effective in the treatment of acute lateral ankle sprain. This slide shows the evidence-based guidelines for return to work in sports, as outlined by a recently published evidence-based clinical practice guideline in the British Journal of Sports Medicine. So protected return to full work in sports occurs 3 to 4 weeks in grade 1 injuries, 6 to 8 weeks in grade 2 injuries. That's pretty consistent with what I talked about earlier. Both grade 1 and 2 injuries can be optimally loaded and protected range of motion using an ASO or an ankle stability orthosis immediately. And grade 3 injuries often require mobilization for 2 to 6 weeks in either a cast or a walking boot. A transition to a more functional brace should be made as soon as possible, keeping safety in mind in order to prevent the onset of ankle stiffness. And lastly, there's also many interventions available for chronic ankle instability. In this presentation, again, we're going to look at just the A-level evidence with a strong recommendation. So there's a consensus across current research that therapeutic exercises are effective in patients with chronic ankle instability. As with acute ankle sprains, the programs studied are very heterogeneous, which makes specific recommendations with regard to frequency, intensity, and type of exercise difficult. But just as broad categories, PTs should utilize proprioceptive and neuromuscular training to improve dynamic postural stability and the perception of stability in patients with chronic ankle instability. There's also strong evidence to support including manual therapy in the rehab of patients with chronic ankle instability. Manual therapy improves short-term ankle dorsiflexion range of motion, ankle strength, balance, functional test performance. And again, the available evidence does not show benefit for one treatment technique compared to another, so it's left to your discretion which technique to use. And broad categories that you could be used that have shown benefit include joint mobilizations, manipulations, and mobilizations with movement. PT should consider techniques in both weight-bearing and non-weight-bearing positions, though. All right, so that takes care of the formal portion of what I was going to talk about tonight. So what we're going to do is it's a poll. So you'll see this poll launched here in a second. All right, so I'm going to throw up a slide here that has a question on it, and there's a list of answers, and each of you can vote for a specific answer there. I'll give you about a minute to answer each question. So this is the first question here that we have. So go ahead and take a look at it, and then whenever you're ready, you can start putting in your answers on the poll. We'll give everybody about another 30 seconds or so. All right, looks like most people have had a chance to answer. So I'm going to share the results with each of you. So most people on this one, they chose letter A. So let's take a look at some of the key information from the questions highlighted in red here. So we're talking an acute injury, difficulty bearing weight, and we're concerned about a possibility of a fracture. So we're thinking the Ottawa ankle rules with this one. And so which one is exam findings most consistent with Ottawa ankle rules? And so again, that's good job. That's letter A for those of you that chose letter A. Auto ankle rules developed to provide clinicians with guidelines for determining when to order an X-ray following an acute ankle injury. So palpation and tenderness of either malleoli are one of the criteria. Now let's do that. And I'm going to relaunch the poll and we'll go to the next question. All right, so I'll let you go ahead and read that. Take a minute or so to throw in your answer. Give it another kind of 10 or 15 seconds to answer. Anybody that wants to answer? All right, we'll share the results here. So most people, a little over half of you guys chose letter C, and then a mix of A, B, and D for the other one. So let's take a look at, again, the key information. Acute injury. This time the auto ankle rolls are negative, and we have positive anterior drawer and reverse anterolateral drawer tests. So what's one test or measure that should specifically included in the exam of the patient? So we're thinking this is an acute lateral ankle sprain. And so the weight-bearing lunge test is the one that the clinical practice guidelines specifically recommends. Dorsiflexion is usually a very common and significant impairment in people with lateral ankle sprains. They may have some reduced ankle plantar flexion strength. The neurological screening is usually normal. And then Thompson's test, if you think back to your orthopedic content, Thompson's test is a test for Achilles tendon injury. So not really suspecting it in this one, although those of you that chose that may be kind of thinking the pop there. But again, the key information is they're describing the inversion type of injury. All right, so I'm going to stop sharing this one and relaunch the poll again. Whenever you're ready, take a minute or two, read through the question and put your most preferred answer in there. All right, guys are getting a little bit faster, so I'll go ahead and end this one and share the results. So we're kind of an even split here. We're going to duel it out between letter B and letter D. So let's look at some of the key information. So really the key piece of information here is we want to reduce risk for recurrent injury. This is one of those tough board questions. I think those of you that chose B and D are probably thinking along the right lines. If you're thinking D, you're probably definitely thinking like neuromuscular type exercises, things like that. But the correct answer on this one is actually B, prophylactic ankle bracing. This is like secondary prevention versus primary prevention. So this is in the realm of secondary prevention where they've already had an injury, and so you're trying to prevent that second type of injury. So prophylactic ankle bracing is one of those that has been shown to be very effective for that. All right, next question. You can go ahead and read it, and I'll put the poll up here. Yeah, it looks like everybody's, for the most part, got something in there. Good. Share the results. So a lot of people choosing A and B. So let's see what we have for our key information here. multiple significant ankle sprains, reports them giving away, and perception of ankle instability. So we're thinking chronic ankle instability with that. And then they have reduced physical performance on functional tests. So it's another kind of indication for chronic ankle instability. So really the question is asking what is the best intervention for chronic ankle instability to improve function? And so on this, the correct answer is A. So B, another good, very typical board question. Answer B is not incorrect. Um, but according to the clinical practice guidelines, this is the most evidence, has the most evidence for it, the neuromuscular training. So proprioception type exercises, balance type exercises. Those are the exercises that you really want to think about when you have a patient with chronic ankle instability, according to the clinical practice guidelines. All right, so now we'll do one more question if everybody's up for it. Here's the last question. A little bit more simple on this one. Yeah, awesome. So I think it's almost everybody that has been responding, but everybody's all responding the same. So I'll just go ahead and throw this one up there. You guys got it exactly right. So ATFL, what's the clinical test? And that's the anterior drawer test. So good way to finish, finishing strong. Everybody got that one correct. All right, so what I'm going to do now is just open the floor to questions. So I've already had one in the chat, so that's great. And if anybody else has a question, the easiest way to do this, please just type it into the chat box and I'll answer those questions as they start to come up. And so if you're typing in now or thinking, I'll answer the question that's up there. And then anybody else, feel free to type in any questions that you have related to this topic, or if you do have any other orthopedic topics, happy to answer those. If you have any neuro or any other type of body system questions, that's not my lane, so I wouldn't ask me those things. I could do my best to answer, but I wouldn't necessarily trust what I answer. All right, so the question was, are proprioceptive exercises recommended over bracing in chronic instability versus acute? And that's exactly correct. So for acute injuries, the bracing is the one that is most recommended to prevent the recurrence. Versus in the chronic conditions, you may use a brace, but you definitely want to be working more with the proprioceptive exercises and the neuromuscular training exercises. And then the next question kind of goes right along with this is, can you explain what prophylactic ankle bracing is? And you guys are probably familiar with an ASO, an ankle support orthosis, or just an ankle brace that you could go to CVS or Walmart to buy. A lot of these that are more effective in bracing, they kind of simulate what an ankle tape job would do. They have very rigid straps that wrap around the ankle if you're not familiar with them. So a lot of times if you go to CVS, you'll get like a neoprene sleeve that just kind of compresses the ankle. That's not necessarily what we're talking about with this one. These have hard canvas straps that you can wrap around the ankle and they'll simulate the exact action of what ankle tape job would be. The reason that they're actually a little bit better than taping to prevent injuries, and number one, they're more cost effective. You would think that a brace that costs $20 would be more expensive than the tape that costs like $1 a roll or 50 cents a roll or whatever it is. But when you're doing it for sports and you multiply it out over the course of the season, the ankle brace actually comes out to be cheaper. But then the other benefit of the brace is if you were an athlete or still are an athlete and never had your ankles taped, you know that once you have it taped, like within 10 or 15 minutes, that ankle tape starts to get loose. It loosens up a little bit. So if that happens and you have a brace on, you just tighten it up. But that ankle tape, once you start adding layers of tape over tape, it gets uncomfortable and heavy, and it doesn't really work as well. So that's another reason that bracing might be a better option. However, athletes, the taping is lighter. A lot of times they're going to like bracing a little bit better. And then depending on people's footwear, sometimes the brace is a little bit bulky. It may not fit into the full footwear that they have. So those are just some of the considerations that you'd have with the prophylactic bracing. And I think you can throw taping right in there with that. All right, so anybody else have any questions, please go ahead and shoot, and I'll stay here as long as everybody wants, but if nobody has questions, we can sign off whenever as well. All right, well, that looks like everybody as far as questions. So again, thank you very much for those that joined us tonight. Those taking the exam in April, best of luck. Hope you do well, and thank you again.